All right, so the areas that we're gonna cover includes aortic stenosis, well, aortic valvular disease. So the left-sided valves to a great extent, but we're gonna discuss the right-sided valves as well. But most of your pathology, or not most of your pathology, but significant pathology usually occurs on the left side. And when you have left side disease, you get more clinical picture. You tend to have more symptoms and signs, and you tend to be sicker. So we'll probably spend a little bit more time on the left-sided valvular disease. Okay. So some things that you need to know, basic stuff. There are four valves, of course, two on the left and two on the right. The left-sided valves are your aortic and your mitral. The right-sided are your tricuspid and pulmonic. Even though in terms of sickness, you tend to be sicker with the left-sided valves. Exams, the current trends in the exams, they like to bring a lot of right-sided valvular disease as well. So you need to know it because it's one of the exam favorites. So you need to know it. Valvular heart disease is very common. So you need to have a very good understanding of your regurgitation, your stenosis. You can have other things affecting the valve, such as vegetation. So you need to know the different pathology that can affect the valves. And it sometimes it's good if you can see the patient and sort of have something going in your head. Is this aortic valvular pathology? Is this aortic stenosis? Is this aortic regurgitation? Is this mitral stenosis, mitral regurgitation? So the signs and symptoms sometimes will tip you off in that direction. If the patient come with leg edema, ascites, of course, remember ascites is when the abdominal cavity is filled with fluid, and the type of murmur. So if you listen to the patient chest, you can sometimes determine what valvular pathology the patient have. Because aortic stenosis, for example, when you listen to the patient chest, especially in the aortic area, you're going to get what we call an ejection systolic murmur. So it's we use descriptive terms such as a diamond-shaped murmur, crescendo, decrescendo. So it has a rapid rise and then it falls again. So, listening to the murmur, you can sometimes have a clear understanding as to what valvular pathology you're dealing with. Regurgitation, again, if it's mitral regurgitation and you listen to the apex, you hear this systolic, what we describe as a holosystolic murmur. So the murmur can tip you off as to what valvular pathology you're talking about. In a lot of these valvular disease, the heart is enlarged. And not only the heart is enlarged, but the liver, we call that hepatomegaly. The liver can be enlarged, engorged. And we usually talk about a tender hepatomegaly. When you examine the patient's right flank or right upper quadrant, it's tender because the liver is enlarged and the capsule of the liver is under pressure, so it's very tender. Tachycardia, which is increased heart rate, you can feel the patient pulse, or if the patient is hooked up to some type of monitor, you can see that the patient is tachycardic. So you know that if they have a valvular pathology, it's probably significant. Something we call a third heart sound. Third heart sound in older patients tend to means that the patient is in heart failure. And then the fourth heart sound suggests that the atrium is contracting vigorously. So in addition to 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 what the referral that you get to do the study, by just looking at the patient and sometimes examining the patient, you can determine what is going on. All right. Again, shortness of breath. Some of the symptoms are shortness of breath, fatigue. Patient tell you that they're very tired and lethargic, dizziness, syncope. Remember, syncope is usually associated with aortic stenosis. Okay, the cardiac output is fixed, and these patients, if they exert themselves, the cardiac output cannot increase to fit the demand, so they'll pass out. Chest pain also common with aortic stenosis, because the heart muscle hypertrophy gets thickened, and you tend to get what we call subendocardial ischemia. You don't get enough blood flow to the subendocardial area. Hemoptysis, this is more common with mitral stenosis because of the increased pulmonary pressures, pulmonary venous pressures, and the patient can cough up copious amount of blood. So hemoptysis is the coughing up of blood. And then palpitation will go along with, if the patient have any type of tachycardia. Atrial fibrillation is common with, say, mitral stenosis or mitral regurgitation. So the patient may complain of palpitations. Okay, and again, signs: leg edema, swelling of the leg, ascites, fluid in the abdominal cavity, murmur, and the murmur may be classic, because for regurgitant murmur, you're going to get an systolic murmur. If it's mitral regurgitation, the murmur is in the apex of the heart, at the apex of the heart. If it's tricuspid regurgitation, then the murmur is at the left lower sternal border. If it's aortic stenosis, you're going to get, as we said, an ejection systolic murmur or a diamond-shaped murmur, and that's going to be heard in the aortic area, which is the second right intercostal space. Cardiomegaly, we talk about that enlargement of the heart. Some valvular pathology will give enlargement of the heart. Hepatomegaly, the liver is enlarged, and not only hepatomegaly, but you get tender hepatomegaly. The liver is tender because the capsule is stretched. Tachycardia, this could be sinus tachycardia, it could be atrial fibrillation, atrial flutter, any type of tachycardia. Third heart sound suggestive of heart failure, fourth heart sound. Okay, so what are some of the causes for valvular heart disease? Rheumatic fever is very common in the tropics, okay, as opposed to the more developed countries. You tend to see more congenital and senile pathology, which is senescence, heart valve disease due to aging. Okay, so rheumatic heart disease, congenital heart disease, and one of the most common congenital heart diseases is bicuspid aortic valve. Instead of the aortic valve having 3 leaflets, our cuspid has 2. Infective endocarditis, okay, infective material can build up on the valves. Trauma, okay, so remember, trauma can cause significant valvular pathology. A common scenario: patient driving unrestrained, the car collide with something and the steering wheel hit the patient in the chest. You can get a tricuspid valvular rupture and significant tricuspid regurgitation. That is fairly common. Tumors can affect the valves. I mean, a myxoma can sit on the track, sit on the mitral valve uh, in some scenarios and cause signs and symptoms of mitral stenosis. So a myxoma can can affect the mitral valve. You can have tumors of the valve itself. Okay, so you can have tumors of the valve. Not very common, you know, things like papillary myxoma, connective tissue disease can also affect the valves. Myxomatous degeneration, such as mitral valve prolapse, redundant valvular pathology. So that's the myxomatous degeneration. So these are some of the more common cause. Also medication. So this is on the treatment, but medication, we used to have obesity medication on the market, and they were causing valvular pathology. So it is one of the cause. All right. So how do you treat valvular pathology? We say medication, but the real treatment for a significant valvular pathology is valve repair or replacement, because valvular pathology is a mechanical problem. So you have to treat it with some type of mechanics. All right. So the main treatment is repair or replacement for significant valvular pathology. All right. So let's look at aortic stenosis. Again, when we say something is stenotic, it's narrowed. So this is narrowing of the aortic valve. Okay. As you remember, the aortic valve allows blood to get out of the heart. When the left ventricle contracts, blood flow across the left ventricular flow tract, across the aortic valve into the ascending aorta. So when you have aortic stenosis, the opening of the aortic valve is restricted. The normal aortic valve area is about 3 to 5 centimeters squared. So they commonly ask you these questions in exam to make sure that you know what you're talking about. So this is the normal aortic valve area. Signs and symptoms of severe aortic stenosis. So when we talk about valvular pathology and signs and symptoms, it's usually of severe disease. So when you have severely restricted aortic valve, patient can develop shortness of breath on exertion. Okay, so this is one of the common features of significant aortic stenosis. Whenever the patient exert themselves, they're going to have shortness of breath. Syncope and sudden death. This is another very important feature of severe aortic stenosis. Patients tend to pass out. So when a patient comes to you and you suspect aortic stenosis and they tell you that they're passing out, that's usually an indication to replace the valve. Sudden death, these patients can die suddenly as well. And then chest pain, when you have aortic stenosis, because the heart is working very hard to overcome this obstruction, the wall of the heart thickens and the subendocardial area can become ischemic, which is devoid of blood because the wall is too thick. So the subendocardial area sometimes don't get enough blood, and these patients complain of chest pains because of the subendocardial ischemia. So for aortic stenosis, these are the three, whenever the patient comes to the clinic, these are the three main things we question them about. Shortness of breath with exertion, syncope, which is passing out, and chest pain. Those are the three things we cone in, usually with patients with significant aortic stenosis. Because if they have any one of these, that's an indication for them to have the valve replaced. So when you listen to these patients, when you listen to the chest, someone with significant aortic stenosis, you're going to get an ejection systolic murmur in the aortic area, the second right intercostal space. So the murmur is described as a diamond-shaped murmur because it goes up and it comes down. It's also described as a crescendo decrescendo murmur because it's going to go to a peak and then it's going to come back down. Okay, ejection systolic murmur at the base, common. Aortic stenosis is very, very important, not only for test taking, but clinically, because something we call senile degeneration, which is aortic stenosis because of calcification of the valve and restriction, which is common in patients who are older. And we now have new techniques to treat these valvular stenosis as opposed to opening the patient chest. Once you open someone's chest, that put them at significant disadvantage because now they have to recover from this significant operation and with all the morbidity and mortality associated with that. So we have new techniques where we can replace the valve by just doing a percutaneous procedure, going through the groin and going up the blood vessel that way. So these older patients who used to die because of significant aortic stenosis, we can now impact those patients in terms of treating them without doing open heart surgery. So senile degeneration is one of the most common. It's very common, very, very common, okay? And if you're talking about patients who are over 70, it is the most common cause in these older patients, senile degeneration of the aortic valve. In the younger patient now, if you see someone who is probably 60 or younger, someone who is 60 or younger, and if they have aortic stenosis, it's usually due to a congenital problem with the aortic valve, and usually a bicuspid aortic valve. Okay? So I would say above 60, above 70 is usually senile degeneration. Below 60, bicuspid aortic valve. Okay? Acute rheumatic fever can give you aortic stenosis. Not very common though, so never mention that. Endocarditis with the vegetation obstructing the valve can also give you aortic stenosis. But usually when you're talking about aortic stenosis, senile degeneration, older individuals, or bicuspid aortic valve. All right, so this is a case of aortic stenosis. This is a parasternal long axis view. When you look at the aortic valve, you can see it's thickened and there's restriction in the opening of the valve. So the aortic valve is thickened and restricted. It's not opening. And when you plate or when you do your study, you can see that the valve is not opening. So you can make your assessment of aortic stenosis, but you have to go beyond that. You have to calculate the aortic valve area. And we went over this when we did hemodynamics. So you have to know the formula to calculate the continuity equation. That's that's what we use to calculate the aortic valve area. And again, if someone wake you up at 3 in the morning, you should be able to recite the formula. Any exam you do, they expect you're going to get some question to calculate the aortic valve area. So again, aortic valve area is 0.785 times d squared times the LVOT TVI divided by the aortic valve TVI. Okay? And we show you how we simplify the formula to get to 0.785. When we say D, this is the LVOT diameter. So D is the LVOT diameter. Okay? And you square that. All right. So that is your LVOT diameter. Okay, short axis, you can also see the restricted opening in the valve. Okay. When you do M mode, the M mode features of significant aortic stenosis, thicken leaflets, and you can see that decrease cusp separation. You can also see that. So this would be a normal aortic valve. So the M mode cursor is across the aortic valve. You can see, so the aorta, this is the aorta right here. The aorta, the aortic valve is inside, thin cusp, okay? And not only that, what we call this the closure line. The closure line is usually in the center, okay, as opposed to a bicuspid aortic valve where the closure line is off-centered. And we have a separate lecture for M mode, and we'll do that. This is a patient with aortic stenosis. If you look at this is the aorta. You look, the aortic valve is inside. The aortic valve is, when it opens, it's sort of box shaped, triangle, rectangular. You can see it's thickened. You can see the leaflets are thickened, and the cusp separation is restricted, okay, or decrease cusp separation. So in the 5-chamber view, okay, 5-chamber view, you're going to get your LVOT TVI, okay, LVOT TVI. And again, remember, you need to put your cursor outside of the zone of flow convergence, okay, outside of the zone of flow convergence. If you get a TVI, which is upwards of 26, 27, close to 30, you know you're too close. The normal LVOT TVI is about 18 to 25, 26. If you're too close to the valve, you're going to get a much larger LVOT TVI. So you know you're too close. So you need to be outside the zone of flow convergence, not too close to the valve. So that's your LVOT TVI. This is your aortic valve TVI. So the cursor, the sample volume should be right in the valve itself, and you can see your CW, and once once you trace the border of the envelope, you'll get the aortic valve TVI. So again, the formula is 0.785 times D squared times the LVOT TVI divided by the aortic valve TVI. So you have to try and get accurate numbers. So when you put it in the equation, you get accurate figure. Because if you do sloppy, if your measurements are very sloppy, you're going to give the patient something that's not accurate. So you need to, pay a lot of attention when you're doing that. And then not only that, when for the aortic for the aortic valve TVI, you have to use multiple windows, because remember when we did Doppler, you're not sure where you're going to get the eye's velocity. The eye's velocity is dependent on your ultrasound beam being parallel to blood flow. So you have to use multiple windows. You not only have to use multiple windows, you should learn to use the PDOF, the imageless probe. Okay? And this, if you follow what was going on here, this is your apical, well, it's a 5-chamber view, and you get a TVI 95. This is, I think, a 3-chamber view, TVI 53. And this is the imageless probe now. With the imageless probe, you get 114. Sometimes the highest TVI is obtained by using the pencil probe or the imageless probe, because you want to manipulate your ultrasound beam so that the ultrasound beam is parallel to the flow. Okay? And when you plug it in the equation, remember your continuity equation, the flow at the LVOT is equal to the flow at the aortic valve. Anywhere inside the heart, the flow is the same. Remember, flow is equal to cross-sectional area times the TVI. So the flow at the LVOT is equal to the flow at the aortic valve area. And remember the area, we assume the area to be the cross-sectional area. We assume it to be circular. The area of a circle is pi r squared. Okay? So once you put that in the equation, when you simplify it, you get 0.785 times d squared times the TVI across the LVOT divided by TVI across the aortic valve. You have to know the formula. You have to know how you get the formula. Okay? All right. Again, you're going to interrogate the aortic valve from multiple windows because of the Doppler, because you're using Doppler. And you want to minimize that angle between the ultrasound beam and the flowing blood. Okay, these are the different windows. You can use the apical 5, apical 3, right parasternal, suprasternal, and of course you should always try to use the pencil probe, the peel off. Okay, very important. All right, so this table, you have to memorize it. For those of you who are doing exams, you have to memorize it. You have to know it. Okay, there's a slight update. We'll do the updates, but this is the basic. Okay, you have to know what's severe. Okay, if you look at the aortic jet and if the velocity is more than 4 meters per second, it usually suggests that you have severe aortic stenosis. The mean gradient above 40 millimeters mercury usually suggests you have severe aortic stenosis. Valve area by the continuity equation, if it's less than 1 centimeter squared, usually it's severe. When you index the aortic valve area, so you get your aortic valve area and you divide it by the body surface area. And if it's less than 0.6, then it's severe. The dimensionless index or the velocity ratio. Okay, so what you're doing, you're taking your LVOT, usually the TVI, and you're going to divide it by the aortic valve TVI. We call that the dimensionless index. You can also use the velocities as well, but it's more customary for you to use the TVI. So it's the LVOT TVI divided by the aortic valve TVI. If that's less than 0.25, it suggests severe aortic stenosis. So you have to know mile now. So if the velocity is between 2.6 and 2.9 meters per second, suggests mild aortic stenosis. If your mean gradient is less than 20, suggests mild. If the valve area is greater than 1.5 centimeters squared, then it's mild. And then index, if it's 0.85, velocity ratio greater than 0.5. And then anything that falls between mild and severe is moderate. So you don't really have to memorize moderate. You need to know what's mild and then what is severe. Then we talk about aortic sclerosis. We see a lot of patients who the aortic valve is thickened, there's not much restriction, and some people, will call it mild aortic stenosis, but it's really not. Usually these patients, the velocity across the aortic valve is usually less than or equal to 2.5 meters per second, okay? But usually severe, you have to know what is severe aortic stenosis, okay? All right, so we're going to stop here. And, you need to, aortic stenosis is so common. This is one of the bread and butter thing we should be able to thoroughly analyze and assess aortic stenosis. Clinically, in terms of examining the patient, getting a history to see if this is significant aortic stenosis, and then when we do the echo, we should be able to accurately determine if this is severe aortic stenosis. What we'll do is we'll present, as I said, there's some updates, not a lot, where they classify a group of patients as very severe. So we have severe aortic stenosis and very severe. So the very severe aortic stenosis, if the velocity is now greater than 5 meters per second, and then if the mean gradient is greater than 50, greater than 60. So we will go over those new guidelines. So on Saturday, we will probably do a little bit more update on aortic stenosis. Okay? But you can make certain errors. You can make certain errors when you're doing when you're evaluating patient for aortic stenosis. So you have to know, where you can make these errors and try to minimize them. All right. So we're gonna stop here, and sorry about the technical problems, but yeah, we'll Saturday. I think Saturday at 8 o'clock. Okay. All right. All right. Good night.